Now let's explore how to operationalize a peer support program. Joe, you spoke a little bit already about the existing programs such as EAP and psychiatry. Can you tell our audience a little bit more about why it is important to have a peer-to-peer and what that really looks like and how that helps build resiliency?
I certainly can, Dana. One thing that we noticed was, well, we decided to go ahead and start peer support. So we did model it again after the first responders, and we had group peer support offered. And what we found was that it really worked well for certain members of the healthcare team. So, for example, after an adverse event, we would say, we're going to have a group peer support offered in the anesthesia lounge at noon. And a lot of times, so many different people from the healthcare team would show up. There'd be nurses, patient care assistants, managers, all sorts of different people. But we noticed that rarely were physicians showing up. Maybe a resident would be there, not likely, but sometimes. But the physician, attending physician, the faculty physician, would rarely be there. Or if he or she was there, it would usually be in the role of team leader. And, you did great, and it's okay, and thanks for all your hard work. But we never saw a faculty physician say, I feel terrible. I feel incompetent. I'm really feeling afraid. And what we understood was that's probably a cultural issue. So we decided to look into that further, and we did a survey of physicians in particular, because they were the most, they utilized the group peer support least. Mm-hmm. And we asked a lot around emotional stressors, all different kinds, and what they'd experienced over the past year. And there was a high % of physicians who had experienced some form of significantly emotionally stressful event within the last year. And we specifically asked about adverse events. Who, if you were involved in an adverse event, who would you want to get support from? And we gave lots of choices, EAP, all sorts of other resources, again, which we have so many of. And almost 90% of physicians wanted to speak to a peer. In this case, a physician colleague. Mm-hmm. So what we did was we modified our program. We still have group peer support, which can be very helpful, especially if a whole team is affected. But we also have it for one-on-one for physicians. Mm-hmm. Then we also noticed, and also clinicians who are maybe at the sharp end of an error. Mm-hmm. The nurse who's actually been the person who put the wrong medicine in the IV, a group peer support is not really going to be helpful mm-hmm. to that person, most likely. Mm-hmm. So we modified the program. We added this one-on-one peer-to-peer support. Unfortunately, nobody called us. So we trained about almost 60 peer supporters, and nobody accessed us. And then we realized, if we look back in our study results, it's pretty obvious that some of the barriers to reaching out to a peer or for any other resource after an adverse event, the barriers like fear of reputation and fear of lack of confidentiality, that we needed to do something to help people hurdle those barriers. And so what we further modified the program for was we don't wait for people to call, we reach out to them proactively. Mm-hmm. And that's been a huge improvement in terms of people actually getting peer support mm-hmm. now.